Have you ever stopped to think about what actually happens when a nerve gets damaged? It's not just some simple break. It's really the start of this fascinating, microscopic journey of self-repair. We're going to explore the incredible story of how our body's own wiring system tries to fix itself. So to really understand the repair, we first have to understand the hardware. I want you to think of a peripheral nerve not as a single wire, but as a super sophisticated biological cable. At its very core are thousands of these tiny nerve fibers, they're called axons, all bundled up and protected by layers and layers of insulation. This is the system that carries messages from your brain to your body and right back again. So in this explainer, we're going to follow the entire journey of a nerve injury. We'll start with the nerve's blueprints, then we'll get into the drama of the injury and the body's incredible attempt at regeneration. From there, we'll see how doctors grade the damage, we'll explore their toolkit for repairs, and finally, we'll find out what it takes to predict a successful recovery. Okay, so let's start with that blueprint. Because, to understand how a cable breaks and gets repaired, you first have to know how it's built. Now, this is where that cable analogy gets really cool. It all starts with the axon. That's the single core fiber. That fiber is wrapped in its own personal insulation, the endoneurium. Then, a whole bunch of these insulated fibers are bundled together into what's called a fasciculus, which is then wrapped in another protective layer, the perineurium. And finally, all of those bundles are wrapped in a really tough outer sheath called the epineurium. It's just an incredibly robust design. But what happens when that robust design is compromised? Well, this brings us to the moment of injury and the body's incredible built-in response system. So what does happen when the cable is cut? Well, the answer is this fascinating two-part process. As soon as that connection to the nerve cell body is severed, the nerve doesn't just sit there. It begins this controlled process of degeneration. So, the crucial thing here is what happens on either side of the break. The part of the nerve that's further away and now totally disconnected from its power source, the distal part, it undergoes what's called Wallerian degeneration. It basically just withers away. But the part that's still connected to the cell body, the proximal part, it reacts too, dying back just a tiny bit in a process called retrograde degeneration. It's almost like a controlled demolition to clear the way for rebuilding. No way. Absolutely not. In fact, it's just the beginning. After that old path has been cleared, the body kicks into this amazing regeneration phase. And the pace of that comeback is astonishingly precise, 1 millimeter per day. Now, that's not fast, we're talking about an inch a month, but it is a slow, steady, and determined march of regrowth as the axon stump from the healthy side begins to grow back down the path of the old nerve. And you know what's really cool? We can actually track this journey. Doctors look for two key signs. One is Tinel sign. That's a tingling sensation when the skin over the nerve is tapped. That little tingle tells you exactly how far the regenerating nerve has reached. The other is the motor march, where muscles closest to the injury get their function back first, followed by the next ones in line, kind of like a wave of recovery moving down your arm or leg. But what happens if the path isn't clear? Well, if regenerating nerve sprouts hit a roadblock, like a bunch of scar tissue, they can't find their original tube. They get lost. And with nowhere to go, they can form this tangled, often painful ball of nerve endings called a neuroma. It's like the body's healing instinct has gone completely haywire. So this brings us to a really critical question for doctors. Just how bad is the injury? Classifying the severity is the absolute first step toward creating the right repair plan. The classic system for this is Seddon's classification. At the mildest end, you've got neuropraxia. Think of it as a bruised nerve, like when your arm falls asleep. The signal is blocked, but there's no real structural damage, and it recovers fully. In the middle is axonemesis, where the inner fibers are damaged, but the outer tubes are intact, which gives a path for regrowth. And at the most severe end is neurotemesis. The entire nerve cable is cut. This won't heal on its own, and it's going to need surgical help. Now, for surgeons who need even more detail, there's Sunderland's classification. It takes Seddon's categories and basically breaks them down even further, creating a much more detailed map of the injury. It specifies exactly which layers of that cable we talked about are damaged, from just the axon all the way to a complete transection. And this level of detail is absolutely crucial for planning a precise surgical repair. So once the damage is graded, what can be done? This brings us to the doctor's toolkit, a set of strategies designed to either support the body's natural healing or, when it's necessary, to intervene directly. For most closed injuries, the first step is the conservative approach. The goal here is just to create the best possible environment for healing. Splints are used to keep joints in a good position, and physiotherapy helps keep the muscles healthy and ready for when that nerve signal finally returns. After that, you give the body time to heal, with a reevaluation in a few months using special tests to track the nerve's recovery.
But sometimes waiting just isn't an option. In certain really clear-cut cases, a surgeon knows from the very beginning that they need to step in to give the nerve a fighting chance. Surgeons are looking for these red flags. An open wound where the nerve is visibly damaged is an immediate call for repair. Same thing if a nerve gets injured while a doctor is setting a broken bone. Essentially, when there's no doubt that the nerve has been physically severed, surgery isn't just an option, it's the primary plan. And when surgery is the plan, let me tell you, timing is everything. For a clean, sharp cut, the ideal is a primary repair within hours. If the wound is dirty, surgeons might wait a week or two for a delayed primary repair. And for injuries that are discovered late or maybe after an infection, a secondary repair is done after 3 weeks or even more.
The best option always is to suture the two ends of the nerve back together. But if there's a gap, a surgeon can bridge it using a piece of nerve from somewhere else in the body, often the sural nerve from the ankle. And if nerve repair isn't possible or it fails, the final option is a tendon transfer, where a working muscle is rerouted to take over the job of a paralyzed one. This leads us to our final and, let's be honest, maybe the most important question. After all of this, what are the chances of a good recovery? Well, a whole bunch of key factors come into play. First, there's the patient themselves. Age is a big one. Younger patients just heal better. Then there's the injury itself. A simple bruise has a much better outlook than a complete cut. The type of nerve also plays a role, and so do the when and where. The closer the injury is to the muscle and the sooner it's repaired, the better the odds. And get this, it turns out not all nerves are created equal when it comes to healing. Nerves like the radial nerve in the arm, they have an excellent potential to recover. Nerves in the wrist, like the median and ulnar, have a more moderate chance. And unfortunately, some, like the common peroneal nerve near the knee, have a historically poor prognosis for recovery.